treat articulation errors in the population of pediatric cleft lip and cleft palate. Due to oral structure abnormalities, this group is often characterized by errors including misarticulations of consonants like substitutions and omissions, which impact their overall speech intelligibility. Because of this, traditional articulation therapy is particularly beneficial for this population. However, I was curious about whether or not traditional articulation therapy would produce better outcomes when used in conjunction with oral motor exercises. For example, lateralizing the tongue from left to right and pushing the tongue up against a tongue depressor. So, I decided to ask this question. Is a traditional articulation approach paired with oral motor exercises more effective in correcting articulation errors in children with cleft lip and cleft palate than a traditional articulation approach alone? So, before I discuss my research findings, let's first talk about cleft lip and cleft palate. These malformations are congenital craniofacial abnormalities where the development of certain structures like the lips, hard palate, and soft palate are interrupted in utero. A number of different cleft conditions can result from these abnormalities, which can range from unilateral cleft lip to bilateral cleft lip and palate to cleft palate only. It has been recently reported this year by Herrera's Mercado et al. In 2019 that nearly 7,000 infants are born with cleft lip or cleft lip and cleft palate in the United States each year. In terms of treating this population, surgical repair may be necessary depending on severity. Speech and language intervention, specifically articulation therapy, is almost always recommended to address the articulation patterns that result from the different types of clefts. In 2011, Munich and Romanoff stated that due to structure abnormalities of the orofacial structures, these children will experience restrictions on their abilities to articulate, resulting in a limited range of their sound inventories. These errors are often secondary to velopharyngeal insufficiency, malocclusion, and other oral anomalies, according to Herrera's Mercado et al. In 2019. Children with cleft lip and cleft palate will produce obligatory errors, which are likely to resolve once the cleft is surgically repaired. These obligatory errors can include hypernasality and nasal emission, which are the most typical characteristics of cleft lip and cleft palate, as stated by Herrera's Mercado et al. In 2019. This population can also produce compensatory errors, which are learned errors that resolve with articulation therapy. Compensatory errors are typically errors with the place of articulation. These errors are often used to compensate for the irregularity of the articulators and can persist after the surgical repair, since they are learned behaviors. In 2014, Pamplona et al. Investigated different strategies for treating these compensatory articulation errors in patients with cleft palate. The study discovered that scaffolding strategies proved to be effective when correcting errors in place of articulation. The authors concluded that when a strategy is based on the severity of the compensatory articulation errors, the patterns are more easily corrected. In 2013, Bessel et al. Confirmed that traditional articulation approaches that target atypical speech productions are commonly used for children with cleft lip and cleft palate. However, their systematic review discovered a lack of evidence to support any one specific intervention above another as best practice for treating articulation errors in children with cleft lip and cleft palate. So, my research confirmed that traditional articulation therapy in general has been proven to be effective in treating articulation errors, specifically compensatory errors seen in children with cleft lip and cleft palate. However, I still wanted to find out if there's an impact on articulation errors by adding oral motor exercises to the mix. I first gained exposure to oral motor exercises while using them on a client with apraxia of speech during this semester's clinic. The reason for doing so was to increase her awareness of tongue placement and jaw stability. The exercises were paired with a more traditional articulation intervention in which we noticed significant progress. So, I wanted to see if this would occur in a population that has always sparked my interest, cleft lip and cleft palate. Oh. There is some uncertainty surrounding the effectiveness of oral motor exercises. There's been debate about whether any progress with speech sound production can actually be attributed to the exercises when implemented in articulation therapy. It has been claimed that our oral motor exercises do not put enough force on the oral muscles that would be required for strengthening them, thus not affecting speech sound production. According to McCulley et al., when the exercises are not used alone and are instead used with more traditional approaches, the results can be beneficial. Specific oral motor exercises can be selected to focus on the oral structures involved in a client's target sounds. If not to directly strengthen the structures, like most of the evidence refutes, the exercises can be used to increase awareness of placement and control of the oral structures. During my research process, I searched PubMed, ASHA evidence maps, and the LSU HSC library databases for terms including cleft lip and cleft palate, articulation intervention, and oral motor exercises. Since my population of interest is children with cleft lip and cleft palate, I narrowed the articles down to only those including studies with pediatric populations. My research included 3 systematic reviews, a single subject design, and a quantitative study. Unfortunately, my search yielded results that were pretty broad, and my topic was rather specific in comparison. With that being said, I was still able to acquire some quality information about articulation errors and intervention with cleft lip and cleft palate. However, information regarding the combination of articulation therapy and oral motor exercises in this particular population was sparse and difficult to find. Although this was a topic of interest for me, research on oral motor exercises within cleft lip and cleft palate is not as common as I thought it might be. After looking at the evidence, I discovered that traditional articulation therapy is currently the most effective intervention for treating speech sound errors in children with cleft lip and cleft palate. There is definitely no evidence to support the independent use of oral motor exercises, but there is some evidence supporting that they can be used in addition to a traditional approach to increase awareness of oral positioning and placement. As long as this isn't the only form of intervention being offered, oral motor exercises can help the child become more conscious of their placement and, as a result, perform more accurately on traditional articulation tasks. So, maybe we can get the best of both worlds by using both of these approaches together.
Absolutely.
Further research on oral motor exercises joined with a traditional approach can be done to learn more about their effectiveness on articulation in cleft lip and cleft palate populations. Does anyone have any